Hi, everyone. This is Lauren. I am happy to share my Group Muddy Points discussion points with you all today. So in reviewing the Muddy Points themes from Module 8 that Dr. Wapner posted in our group, it appeared that my classmates had very similar questions to the ones that I had had while finishing up the module. In general, people wanted to see more practical examples of how causal loop diagrams are created through group model building. And they needed to see how this process actually leads to any behavior change on the part of stakeholders that are involved in solving a health problem. And then lastly, they wondered about why these teaching topics were combined with the topic of leadership styles in public health. How are these things connected? So in order to answer these questions in a new way, I wondered about if I could find one clear, real-life example that touches on all of these different components. And I started looking online for examples of public health policy and program changes that were influenced by the results of group model building, or if there was some relation there. So Muddy Point 1, addressing practical examples of reference modes, variable elicitation, and feedback loops. And so I started looking online and I found this study, which is entitled Community-Based Systems Dynamics for Reproductive Health, an example from Urban Ohio, USA. I was actually really excited to find this as this publication actually came out of the OSU College of Public Health. It was published in 2022 in the journal Progress in Community Health Partnerships, Research, Education, and Action. And so I thought this paper actually was a fantastic example of really describing in detail what this process actually looks like for group model building and causal loop diagram formation to get to the endpoint of having objectives that you could clearly translate into policy changes. And so I wanted to describe what they did in this study. So what they did was the group conducted group model building sessions. They did them through half-day meetings, and they had group discussions that were facilitated as well as scripted activities. And the participation in these groups were really well thought out. So they had people from the Ohio Collaborative for Preventing Infant Mortality, the Health Equity Advisory Working Group of the Health Policy Institute of Ohio. They had people from LARC Access Ohio, and LARC here stands for Long Acting Reversible Contraception, from the Ohio Better Birth Outcomes Initiative. And so you can see here with the list of participants, they had a mix of people from community organizations, from local city and county health departments, from the state health department, from the Medicaid program. They had medical providers, they even had a patient, and then of course the study team from Ohio State. The team conducted a total of 5 group model building sessions over the course of a little more than a year. And in between the sessions, these study team members were really forming more robust partnerships with these community partners, because in between sessions, they were working together on some of the outputs from the sessions, which we'll talk about. And on the right here, I've just included their table 2 from the article, just to give you an idea of all of the stakeholders that they thought to include here. And so you can tell they've been really, really thoughtful with it in terms of different professional backgrounds, patients, patient advocates, just a really nice, well-rounded team that they took the time to prepare in this study. So this brings us up to another muddy point that the students had from these modules. I said that in this study, the group conducted group model building, and in fact, one of the muddy points that our class had was just wanting to know some practical facilitation tips or pearls for conducting a group model building session in order to build a causal loop diagram. And so I pulled out what I thought were some really nice skills and tips that the team from this study at Ohio State used in their group model building experience. So Within the study team, looking at number 1, they included some content experts from reproductive health and also content experts in systems dynamics and group model building. 2, the big theme I was getting was just you have to be prepared for these sessions. So they did hold practice sessions beforehand. And then 3, they developed a facilitation guide for every group model building session that they had. So they had, with that, they had minute by minute agendas, they had instructions for each activity, how to set up the room, what role each person was going to have. And so there were a number of others that I thought were helpful, but these were just some good pearls that I took away from reading this study in terms of how to conduct a group model building session well. This is just continuing on with the muddy point of wanting some tips on how to facilitate a good group model building session. This comes from table 3 from this same study that we've been discussing. The text is a little too small to read, but I include this here to say that this team had, for every group model building session, they had a very specific purpose. They had several listed objectives for each of the sessions that they were going to conduct, and then they had specific activities that they were going to use to achieve those objects. So in general, keeping things very prepared. They did a lot of work ahead of time. They had scripts, they practiced, they had clear goals for all of these sessions. So really the main goal of the first group model building session that this group did was to clarify the problem statement. The study team had come up with a problem statement before the first group model building session, and then by the end, after meeting with all of the stakeholders, the group was able to clarify into this problem statement that you see here. After that, participants in the group within the same session identified 35 different stakeholders that had some role to play in the problem statement. And then they organized those stakeholders based on the amount of power they had to help the problem and the interests that they might have in working on the problem. Then after they did that, the group participants identified 27 different policies that were relevant to this problem statement. And so then with all of that information, the participants drew graphs over time, which we learned in class as reference modes, and I have pictures of those, for each of the outcomes listed in the problem statement. This is just getting to the muddy point of wanting to see some practical examples of reference modes. So this is still from the same study, looking at graphs over time, which must be a synonym for reference modes because that was how the paper was referring to them, as graphs over time, but pretty clearly like our reference mode example in our lectures. So this particular participant was looking at the percentage of Black midwives and care providers over time, with the hope that those numbers would increase based on interventions that the group was going to do. So the reference mode really shows you, what's happening. And here's an example of one of the causal loop diagrams that the group model building sessions generated. So if the reference mode shows you what is happening, the causal loop diagram is really here to show you why is it happening. All of the larger contextual factors that play into the health behavior or the outcome or the trend that you are seeing. And so the construction of the causal loop diagrams actually occurred in session 2 for this study. The authors, kind of getting back to some of the facilitation tips, the authors mentioned how they had to manage the participant participation equitably to prevent groupthink, and kind of discussed some of their strategies to keep everybody on task and to keep everybody participating equally, which I thought was a good tip. One of the other muddy points for the module was students wanting examples of feedback loops. And so the red circle on the right, I've actually outlined a feedback loop, basically where you're seeing infant health and low birth weight preterm birth, with an arrow pointing toward maternal and paternal health, mental and physical health. Ultimately, we know that preterm birth and the stress of that, and the stress of having an infant in poor health impacts maternal and paternal mental and physical health significantly. And then in turn, parents' mental and physical health then places babies at an increased risk of having poor health outcomes themselves or being born preterm if the parents are not in good health or not in good mental health. And so that's an example of a feedback loop from this practical example of this study. The red circle on the left is depicting one area that we're going to go into a little bit more as an example of how a causal loop diagram can actually precipitate real world change. And so that is looking at diversifying the workforce development for more people of people of color, more Black practitioners, etc., and increasing cultural concordance within the reproductive healthcare space. In terms of variable elicitation, each of the green boxes depicted here represents a different variable that was brought up. And again, this is just one of the causal loop diagrams that was created for this. So I think one of the biggest money points for a lot of students and for myself was, okay, this framework, this visualization model seems really helpful, but how does it actually translate into policy and changes at the organizational level to help get us the outcomes that we want? So how does it do that? Through policy levers. Policy levers was a new term for me that I actually learned from this paper and some of the reading I was doing and doing this assignment. But basically, it is a term that describes an opportunity that you've identified from your causal loop diagram to create or change policy. So basically, it can point to a feedback loop in your causal loop diagram where you think maybe if you can intervene with one of those arrows that it might either stop or reinforce the loop depending on what you're wanting. And so I've included table 5 from this paper here just so that we could see some practical examples of potential policy ideas that would support increased reproductive health for women in urban Ohio based on what the group model building sessions had to say. And you can see there's several different potential policy changes here that would be supportive of reproductive health at multiple different levels. So the paper that I've been referencing up until this point from the OSU College of Public Health is noted to be a work in progress as it was published. And so we don't have all of the results in terms of what the outcomes are long-term from these group model building sessions to know were there any specific policy changes related to this study in particular. But what I've done is basically try and look for policy changes within recent years in the state of Ohio that are consistent with what the outcomes of the group model building sessions and the causal loop diagram were in this case. So we'll just pretend. These are real things that did happen in Ohio. And so it could be very plausible that, outcomes like this could come from sessions such that the study team did. So when we look at policy changes that were consistent with the causal loop diagram leverage points, I wanted to point out an image that I found here, which comes from the Ohio Medicaid website for the Mother and Infant Support Program. This is just a timeline over the last 4 years in Ohio, and if you look, a lot of these interventions that they are mentioning here on the timeline are consistent with some of the goals and priorities that were established in the causal loop diagram from that study. So to address low support during and after pregnancy, Ohio Medicaid gave doulas provider status and created a standardized doula certification pathway, which ultimately makes their services reimbursable under Ohio Medicaid. To address access, Medicaid enhanced coverage for lactation supplies and extended the time frame for which pregnant and postpartum members are eligible for Medicaid, among other changes. So if you think back to one of the reference modes that I pictured here from the study from that OSU group, one of the stakeholders had mentioned that their hope was that there would be an increase in the percentage of Black doulas and Black care providers to provide more culturally concordant care, knowing that that will improve health outcomes for our pregnant individuals. And so we see now that there's actually a change in Ohio law that is consistent with what some of the policy ideas that were generated from this causal loop diagram were. So to address bias in the reproductive healthcare workforce and lack of cultural concordance in the workforce, the Ohio General Assembly recently created and codified a doula advisory group, which is tasked with advising the Board of Nursing on doula certification rules, advising the Medicaid program on coverage of these services, and helping provide guidance on who can get doula services covered. And so having these certification rules is really important because that is actually what allows doula services to be covered under Ohio Medicaid. And so the creation of this doula advisory group is reflective of a systems thinking approach in public health. So the legislature created the structure by creating this advisory group. The Board of Nursing is tasked with operationalizing it, and then the advisory board themselves brings the community and the stakeholder voices into the decision making. And within this doula advisory group, the membership of this group is very specific to include members of the community as well, patients and patient advocates. And then the last thing I wanted to touch on is how does all of this relate back to leadership? I think that was one of the main muddy points that came up as well. And I think in reviewing basically all of the videos and podcasts that were assigned for this, what theme came up again and again and again is that if public health leaders are going to be successful in Public Health 3.0 going forward, we're going to need to collaborate with both traditional and non-traditional partners in order to attain success. And Mary Ann Cooney of ASTHO in one of the podcasts had noted that state health department leaders are just fostering partnerships by picking up the phone and by focusing on upstream determinants of health. And some of these creative partnerships, engaging with community members and community partners that maybe in the past public health leaders would not have done or would not have done to the extent that they are now, that type of leadership that we're talking about, that's very hands-on, willing to pick up the phone, willing to get creative, willing to work with partners of all types, and kind of expanding that in a creative way, fits with that term of transformational leadership, such as that is described by Avolio in some of the readings that we've had previously. And so I think that's kind of really how it ties in together. Really, everybody that's involved in a group model building session should be a leader in their own right, and the goal would be to come away from those sessions and take those ideas and disseminate them in your own lane, quote unquote. And so that to me, I think, is how it ties in. So I was really excited to find this example that so concretely took a problem that was local to us in Ohio and focused on issues there, included community members from all different types of organizations, had really nice concrete examples of reference modes, of variable elicitation, of a causal loop diagram, and then being able to kind of follow that up with like, what have we seen in Ohio recently? Again, this was a work in progress that was published by the team at Ohio State, but all of these changes, like the doula advisory group and all of the Medicaid changes in Ohio, are real. And so it's very plausible to think that, people were kind of thinking along those same lines. And so I think the connection of how does this actually translate, it does seem like it can lend you some pretty good ideas that you can then go and make positive changes with. So thanks for listening. Next slide is just my references.